Welcome back. Thank you for staying with us here on Good Morning Kenya. In case you are just joining us, karibu sana. This is Good Morning Kenya. My name is Jane Mbowen. Kama kawaida, I am glad, and on behalf of the entire team, we are glad that you are with us this morning. So we want to continue with our health conversations for the day. Remember, today is Tuesday. We get to pay focus on matters concerning health. Now, we want to switch gears and focus on renal care. But before we get to do that, hashtag is still Good Morning Kenya on Twitter at KBC Channel 1 ever remains to be the official station handle. My handle is Jane Mamboy across all the social media platforms, and we do appreciate you for, talking to us, letting us know where you're watching us from this morning. Yesheruanganga, thank you so much for retweeting and tuning in. I see Benjamin Hanjari, thank you so much for staying tuned. Main Jik, asante sana for staying with us from the beginning. I see Cliff Matt Rianga, thank you for tuning in. Kiplangat Kitur, AY Plangat. I also see Nicholas Tunya. Thank you so much for staying with us this far. We do hope you continue with us on this journey until the close of the program in not too long. But for now, let us get started with this particular discussion, and this is all about renal care. In the recent time, questions revolving around kidney diseases have been taking center stage on both social media and mainstream media. But what really is the background to this renal conversations that we are seeing? What are the reasons as to why, or rather the causes that are bringing about an increased number when it comes to the number of renal cases that we are seeing? Just looking at the information that is there on the World Web, in Kenya, there is an unrecognized chronic kidney disease burden. And this is more so linked to patients who have other underlying conditions, and diabetes has been highlighted as one of those conditions. And also looking at information that was put out by the Kenya Renal Association, if we do not take control of the situation now, by 2030, we'll be having an estimated 4.8+ million cases of chronic disease, chronic kidney disease for that matter here in our country. But what really is kidney disease? Well, that is what we want to find out this morning, and I have with me two gentlemen in studio to help us understand this particular conversation. I'll start with the gent to the extreme right of your screen and my left in studio. That is Dr. Husssein Bagha, who is a consultant physician and nephrologist. Karibu sana daktari.
Thank you very much, Jane.
Thank you for making time to be with us this morning.
My pleasure.
And next to him and at the center of your screen, we have James Chepkwony, who is a renal patient. Karibu sana, James.
Asante sana.
Thank you for making time kuja hapa studio this morning.
Thank you very much.
All right. Now, remember again, you can use the hashtag Good Morning Kenya for any questions or comments or clarifications. Again, as simple or as grand as they may be, we are here to help you better understand these conversations around renal care. So let me start with you, Daktari. When we talk about renal care, it falls under the bigger bracket of nephrology. And maybe somebody is watching us this morning and they're wondering, what is this nephrology creature that we're talking about? So we can start by helping our viewers understand some of these terminologies that we're going to be using today. So looking at your practice as a nephrologist, what does that entail and what does it even mean?
So as a consultant nephrologist, it basically means that I have specialized in taking care of patients with kidney disease. Now, be it acute kidney disease or chronic kidney disease, and also the treatments for both.
Yes.
So when I talk about acute kidney disease, it means that somebody who has been well, perfectly well, has had perfect kidney functions as well, and then because of one reason or another, like gets an acute infection or gets a kidney stone, then tends to get injury to the kidney, what is called acute kidney injury.
Okay.
And most of the time, if that is taken care of early, I mean, we can basically reverse it. Now, chronic kidney disease is diseases affecting the kidney that have been there for a long time. And unfortunately, by the time we say it's chronic, it's not reversible, means that you can't get back to the normal kidney function.
Yes.
And our jobs as nephrologists or kidney specialists is to try and prevent our patients from reaching end-stage kidney disease if we do pick them up early on.
Okay.
And then, of course, offering the various therapies that are available for kidney disease.
And how does the diagnosis towards kidney disease happen? Is it part of routine medical checkups that an individual needs to have, like on a yearly, or looking at a certain time frame that is stipulated for the particular patient, for you as a nephrologist to be able to pick them up? How do you go about diagnosing some of these kidney diseases?
Now, as you mentioned in your introductory remarks, that it is not, I mean, it basically comes about because of other diseases, especially chronic kidney disease. And the two most common diseases that are, that cause chronic kidney disease everywhere, including in the West, including in our setup as well,
yes,
are diabetes and high blood pressure or systemic arterial hypertension. Now, unfortunately, these two diseases are considered or are called silent killers.
Yes.
Because you may be walking around with high blood pressure or high blood sugars, and if you're not checking them, you're basically asymptomatic, meaning that you're not going to be eliciting any symptoms. A lot of patients come and tell me, those who have high blood pressure or those who have diabetes, is that I don't take my medications if I'm feeling okay. I don't have a headache, I don't feel dizzy, so I know that I'm fine, because that means that my blood pressure is okay or my blood sugar is okay. And that is not true.
Okay.
Because even studies have been done and show that you can even be walking around with blood pressures of 200 over 100, which is quite high, and you can be completely asymptomatic.
This is where we have situations of people just suddenly collapsing.
Exactly.
And in unexplainable situations.
Yes. So, once when the blood pressure reaches your, very high levels, or what is called emergency hypertension, then basically they can present even with a stroke or a heart attack. And at that time is when we now start diagnosing the patients to be having kidney disease.
Okay.
So the same thing happens with diabetes as well. So if it's left unchecked, and if somebody is not coming for the regular checkups or regular visits, or if they're not coming for screening, especially when they're high risk, like if you have family history of diabetes and you have obesity, then you're basically at a higher risk of getting diabetes.
Okay.
So then you need to come for regular checkups.
Okay. Now, I want us to just delve into some of those factors that could contribute or predispose you to actually getting some of these kidney diseases. And I want to come to you, James Chepkwony, to just even understand your journey with, it's been about 3 years now?
Yes.
As a renal patient.
Yes.
To just understand your journey. At what point did it occur to you that there could be a problem, but you are not too sure what it was?
At some point 3 years ago, I discovered I was becoming huge.
Gaining unexplainable
a lot of
weight.
weight. And then I was feeling like I could not sleep well. I could not even breathe well. I could not even walk for a long distance. So I became so heavy. And my foot started swelling abnormally. So much that I was feeling some kind of heat in my foot, like some hot water has been poured on my foot. So, and I had been a diabetic patient for a very long time, and hypertensive. So during my normal checkups, my doctor suggested that I go for further investigation for other, maybe there could be a problem with my kidneys.
Yes.
That is when I started now looking for a better facility. I was going to those local hospitals, yeah. Small hospitals without proper investigations. So that is when I was referred to MPSHA for further investigation. Then I met my doctor, Dr. Bagha, who immediately put me on serious investigation, and they came up with that conclusion that I had a kidney problem, a condition, which I think was a bit advanced, because I had stayed with that condition of feeling that.
For how long?
For almost 2.5 to 3 years.
3 years without
without
getting any checkup to just explain some of these symptoms that you were seeing?
Exactly. And because it is not painful. Hypertension is not painful. Diabetes is not painful. It's only when it became so uncontrollable that I started now feeling I must go for further checkup. Yeah.
Now, let me bring you in at this point, Daktari. He has mentioned he had another underlying condition, and that was diabetes and hypertension, which was later discovered when you were doing the investigations? Or it was also before you discovered he had renal conditions?
Well, as I said, that he was having diabetes and high blood pressure, and sometimes a high blood pressure develops as you develop chronic kidney disease.
Okay.
So, I mean, among the things that we always worry about when especially a young person comes to us with high blood pressure and there's no strong family history, then we always worry about somebody having kidney disease as well.
Okay. Now, he has mentioned some of the two things that, could point toward kidney disease, and that is high blood pressure as well as diabetes, other underlying conditions. Now, we'd like to understand some of these symptoms that present themselves that one could just pass for, something that is passing, nimepata kakitu kidogo, I'm gaining some weight, and you don't really explain it from a medical point of view. So let's start with the weight gain. Looking at the fact that James here has mentioned that it happened over a number of years, weight gain in relation to kidney disease, how do they come together?
So there is a very important point he mentioned, and a lot of times most of our patients tend to ignore this symptom. And they feel that, yeah, they're not exercising and they're not fit, physically fit. So this is why they're gaining weight and they're getting breathless, as he mentioned, when they walk.
Yes.
Now, unfortunately, when you have diabetes and when you have high blood pressure, and if you start developing weight gain and if you start developing breathlessness, that's not a good sign at all, because it suggests that your body is retaining water. Normally, one of the functions of the kidney, apart from removing the toxins from the body, is also removing the excess water.
Yes.
I mean, we tend to take in a lot of water, as water itself, as other fluids like juices and other drinks, and then of course our food also contains quite a bit of water as well.
Yes.
So all of that extra water has to be removed from the body, and the main way it's removed from the body is through the kidney. So what happens is you will find that the patients will actually tell you, yeah, I've noticed that over the past couple of months my urine has reduced significantly, and this is when I started noticing that I'm gaining quite a bit of weight, I'm getting very breathless when I walk a few meters, and I can't even lie flat because there's a lot of water within the body itself, including the lungs.
Yes.
But unfortunately by that time the kidney disease is quite advanced. Okay, so when they come to us in this with these extreme symptoms, we almost always have to put them on dialysis immediately.
Immediate.
Yeah, because it is now they've reached end-stage kidney disease, meaning that the kidneys have stopped functioning. All
right, let's talk a bit about genetic factors when it comes to kidney disease. Does it play any role?
Yes, there are some genetic conditions that can predispose you to chronic kidney disease. The most common is your autosomal dominant polycystic kidney disease. And what happens in this case is that the kidneys start developing cysts, which are like balloon-filled structures, but within the kidney itself. And the normal parenchyma of the kidney is actually replaced with the cysts. And especially if you have the autosomal dominant one, meaning that it is dominant, it is passed on from generation to generation, and it can lead to chronic kidney disease. And depending on the type that you get, there's the autosomal dominant polycystic kidney disease type 1 or type 2, you can progress to end-stage kidney disease faster with type 2 as compared to type 1.
Okay. Now, James had mentioned that he also started noticing swelling around the feet and the ankles. And I'm speaking from a point of experience because a member of my family, is undergoing dialysis due to kidney failure. What causes the swelling of feet and even the face sometimes?
So this is basically because of retention of water in the body. So normally what happens is when you wake up in the morning, because of the fact that you've been lying down, you'll find that most commonly it is your face that is swollen because of the gravity. Okay, and then as you get up and start doing your normal chores, and by evening you'll find that because of again the gravity, and you've been standing or sitting for long, it is your feet that tend to get swollen because the water then tends to gravitate downwards towards your feet and ankles.
All right. And another thing that I had also noticed when it comes to some of the kidney diseases, symptoms that I noticed was issues to do with muscle cramps. And sometimes we tend to have muscle cramps randomly. The body decides I need to relax and flex and contract this particular part. But Are there some types of muscle cramps or certain parts of the body that could also be pointing towards kidney disease, or it's not as much a symptom that needs to be paid attention to?
I think every symptom that you get which has not been there before and which has not been investigated needs to be looked at by a professional doctor. So if you start getting muscle cramps, it could either mean that you are dehydrated, meaning that you've not been taking a lot of water.
Yes.
The second thing that can lead to muscle cramps is, of course, your electrolytes, like your sodium, potassium, your calciums. So my plea to the viewers is that please do not ignore any such symptoms. If you do start getting muscle cramps and you've never had them before, or if you've had them before and they've not been investigated, please let's see what's happening. I mean, these are things that can actually point towards kidney disease, like especially if your electrolytes are the ones that are the ones causing the muscle cramps.
All right. Now, let me come back to you, James. You know, the fact that it took about 2.5 years to get investigations done, what information did you have about kidney disease prior to going for the checkup? Ulikuwa unajua nini kuhusu kidney disease?
Surely sikuwa najua chochote. Kabisa.
At all?
At all. Although I had some people talking about kidney and dialysis, I never ever paid any attention to it. So I didn't have any information.
No information
No
whatsoever.
information, yeah.
And what treatment options were you presented with when you visited Daktari to just try and address the situation?
Immediately I was put on dialysis. That was the first thing. And then of course there are medications that comes with it. And so far that is what I'm going on with.
Okay.
Yeah.
And what are some of the lifestyle changes have you had to make to adjust to this new way of living, given you have to undergo dialysis a number of times in a week?
A lot. A lot in the sense that even the type of food you eat has to be, you have to be advised on what to eat.
Yes.
Because before then, I used to eat everything and anything, plus even drinking. I was a heavy drinker.
Yes.
And you can imagine now when it started, and I was drinking heavily. That is a lot of water. And you are going to the loo very few times, and you are drinking up to the morning. So by morning, you can imagine what will happen with all the beers and whatever, meat, nyama choma, tamu sana. So you eat everything and anything,
yes,
uncontrollably. So that contributed a lot to my going down very fast. Yeah.
To the progressing of the kidney
Yeah,
disease.
it
because
really
of the
went
retention.
very fast. Yeah. And then, of course, from when I started now undergoing this dialysis, I was given a list of what to do and what not to do. And that is what has improved actually my condition.
And how many times do you go for dialysis, at least in a week?
Twice.
Twice?
I go there twice, yeah.
Okay.
For
Now,
a session of 4 hours every day.
4 hours per session, twice a week?
Yeah, twice a week.
Now, Daktari, let's talk a bit about the treatment options that are available. As we know it from general information, we know of dialysis and kidney transplant, yeah? So let's start by understanding what dialysis is in itself.
So basically there are two modalities of dialysis. The one that is commonly available in Kenya is what is called hemodialysis, or what as James described, that you come to the hospital, you're put on the machine and you dialyze over 4 hours. We do it for a minimum of twice a week. There are some patients who require more times, like 3 times a week. And what the machine does is that it acts like a surrogate kidney. So you have an access, either a catheter or what is called a fistula. A fistula is whereby we connect an artery to the vein, and that is what we use in terms of the access. So blood is basically removed from the body, it's taken through the machine, it's cleaned up, and then it's basically returned to the body. So you basically remove the excess water, you remove the toxins, you regulate your electrolytes as well, and then subsequently it is returned back to the body.
All right.
Now remember that the kidney works every second, yeah? And yet we are doing dialysis twice a week, okay? For 8 hours, 4 hours in a week. So you can imagine that, yes, we are trying to control the symptoms, but you cannot completely eliminate the symptoms. So the patients have to really help us as well in terms of following the instructions, like what James has said, in terms of your diet, what you can eat, what quantities you can eat, what quantities of water you can drink. That's very, very important, because I've had patients who have dialyzed the previous day and have come in today in extremis because of severe difficulty in breathing, and they're completely fluid overloaded because they decided that after the dialysis they're okay, and they went and drank gallons of water. You see? So unfortunately, kidney disease is a lifestyle disease as well. You really have to conform to the way how your body is now going to be responding. There are some patients who have who are making a little amount of urine, so this kind of helps, and you always try to augment it. A lot of patients are not having any kidney function at all, so they are totally reliant on dialysis. So it becomes very important for them to follow the instructions, for the patients to be advised accordingly as to the amount of water they can drink, as to the types of food they can eat. Remember that potassium is one of the most dangerous electrolytes in the body. And in kidney disease, the potassium tends to be normally very high. So they have to be taking foods that are very low in potassium or avoiding them completely.
Okay. Now, you've mentioned that when it comes to dialysis, it's an alternative to just help with the kidney functions. But at what point does dialysis come into play, looking at the damage that could be done on the kidney? Is it when there's complete kidney failure, or failure to a certain percentage on the functions of the kidney?
Okay, so we normally tend to calculate your glomerular filtration rate, which we can put it in terms of percentages, although that's not entirely accurate. But the normal kidney function is supposed to be more than 90 mils per minute, or as we just said, more than 90%. Now, so the kidney disease, chronic kidney disease, is divided into stages. So by the time you're hitting stage 5 or end-stage kidney disease, your kidney is functioning at less than 15%. Now, normally we would start patients who don't have any other symptoms when the kidney on dialysis when the kidney function is less than 10%. But that's not a hard and a fast rule. I mean, I've started somebody on dialysis who had a kidney function of 14 mils per minute eGFR because they came in with fluid overload, or the potassiums were very high and they were not amenable to medical therapy, or they had very high acid levels within the body as well. So it depends. I mean, it's not a hard and a fast rule, but generally if it falls to less than 10 mils per minute or less than 10%, that's when we start the dialysis for the patients.
Are some of these kidney disease conditions reversible, or once the damage is done, you just work from there moving forward? It cannot be reversed.
Okay, by the time you're having chronic kidney disease and end-stage kidney disease, meaning that you have stage 5 kidney disease, then most of the times it is not reversible. Okay. There are some patients, the younger patients who come in with acute kidney injury, who end up on dialysis. Those ones, especially if they do not have underlying conditions like diabetes, high blood pressure, or underlying kidney disease, then those ones, we can get them off dialysis. Like when they come to the intensive care unit with severe infections or sepsis or septic shock, then we do dialyze them, and then subsequently we do get them off dialysis. But that does not mean that once when you're off dialysis, you cannot be predisposed to getting kidney disease again. Yes, you have to be extremely cautious, and you have to be on follow-up regularly with your doctor.
All right. Now, James, since you started your dialyzing, what are some of those side effects that you have noticed have come along with dialysis in itself, as uncomfortable as they may be, whatever you're comfortable sharing?
What I normally notice immediately after dialysis is a bit of headache, a bit of tiredness. Saa ingine unasikia huwezi kula, the loss of appetite, and you feel so sleepy. You feel so tired, like you ran a whole kilometer, so you need to rest. But after that, you recover, because again, you feel so thirsty, and you have to regulate the amount of water you take. So you can take kidogo, then somehow after some hours, about 8 hours, you recover fully, and you are back to actually normal.
Okay. Are those normal symptoms that one should expect or are associated with dialyzing, Dr.?
Well, initially, yes, you do tend, because see, a lot of times you get our patients who have chronic kidney disease for long periods of time. So they have these toxins that have been in the body for long periods of time. So the body kind of acclimatizes as well and gets used to those toxins. So initially, especially in the first few weeks when we start the dialysis and the body is now getting cleansed of those toxins, there tends to be this symptom that you will tend to get. The tiredness, the fatigue, as he's talking about. Some patients tend to get a bit of headaches, and this is where we start off the dialysis very gently and then build it up from there.
Okay.
But if you're following the instructions and you're not, as he said, that you should limit the water that you're taking, make sure that you only eat what you've been prescribed to eat or allowed to eat, then these symptoms tend to resolve over time as your body gets used to the dialysis, yes.
Okay, so it is expected.
Yes,
but
initially for the first few sessions.
Okay. Now, looking at some of the aspects that James had mentioned, issues to do with weight, water intake, when you are on dialysis, do they come into play when it comes to the amount of water that needs to be removed during the dialyzing process? What are some of those factors that you consider before you determine this amount of water is going to be removed today, then next time you relook at them, then you determine the amount of water that's going to be removed?
Well, that's a very technical question, but anyway.
I'm speaking from a bit of experience.
So, I mean, of course, we tend to ask our patients to limit the water intake. Preferably, it's not only water, it's the entire fluids you can take. You see, like it's water plus your tea, your coffee, your porridge. Everything needs to be limited.
Anything in fluid state?
Anything in fluid state.
Okay.
And then what we do and what all dialysis units do is that we do what is called the post-dialysis weight. So after one session of dialysis, we do your weight. Then when you come again for your other session of dialysis, we do your pre-dialysis weight. Now that weight gain that you have is considered to be the water.
Against the dry weight that you previously had.
And then we also tend to calculate the dry weight using the bioimpedance machines and everything. And then we try slowly to reach the dry weight, which is what our targets are. But unfortunately, sometimes it takes a longer time because some patients tend to get a lot of cramps when you tend to remove a lot of water. So we tend to do it in a graded fashion.
Okay.
Yeah.
Now, as we draw the conversation to a close, I'm being informed we're almost out of time. But there's one tweet that I had seen here. Let me just try and pull it up in regards to treatment and life expectancy. This is Kenai, who's asking, what is the life expectancy when you are on dialysis, in terms of also looking at the quality of life that you live when you are on dialysis?
So you had asked a very important question about the modalities of treatment for chronic kidney disease. I mean, for those patients who have end-stage kidney disease. And as you rightfully said, we have dialysis and we have transplants. So, of course, transplant is whereby we get a kidney, a healthy kidney from a donor, and then we transplant it into the recipient, and that kidney now takes over the functions. And transplant is the best modality of the renal replacement therapy. It has advantages in terms of increasing the life expectancy. So if you take a patient who is on dialysis vis-a-vis a patient who is transplanted, the patient who is transplanted has a higher life expectancy, number one. There are also other advantages as well in terms of the fact that they don't have to come to the hospital twice a week, okay? At least their restrictions of fluids is removed, because if the kidney is functioning very well, then you are able to eat and drink as per, I mean, a healthy diet, of course, yeah? You just can't go back to drinking the whole night and all of, and eating a lot of nyama choma and all of that. Yeah, enjoying nyama choma, which is very sweet, yes. Okay, so definitely, transplant would be the better modality of choice. But remember that for transplant, there's a cost aspect to it, and also the aspect that you have to come with a donor, because in Kenya, we don't have what is called the deceased donor organ program as yet, although we are working towards it, and with the Ministry of Health as a Kenya Renal Association.
Okay, I have Miss Mati here who's asking, if you have a transplant, do you have to be on medication for the rest of your life?
Unfortunately, yes, you have to be on medication for the rest of your life, because remember, you are taking foreign tissue and implanting it in the body of the recipient. So the recipient's body can reject it at any point in time. And rejections can occur immediately. They can occur a few months, a few years, or even decades down the line as well. So you have to be on medications for the rest of your life.
Okay. Now, unfortunately, that is all the time we had for this particular discussion. We weren't able to delve into the transplant part of this conversation. But of course, as I always say, some of these conversations that we get to have here, we cannot fully exhaust them in one sitting. And consequently, we will be having subsequent discussions revolving around this conversation that is renal care, given it is one of those unrecognized burden that we have here in the country, and more so looking at the part of the population that have other underlying conditions. So once again, we will be continuing with this discussion about renal care, looking at, dialysis in itself and kidney transplants as treatment options that are available for renal patients. I have been speaking with these two fantastic gentlemen there that you can see on your screen. That is Dr. Husssein Bagha, who is a consultant physician as well as a nephrologist. Thank you so much, Dr. Ari, for sharing with us from your pot of knowledge.
Thank you.
And we also have James Chepkwony right there at the center, who is a renal patient, 3 years going strong. We wish you the absolute best, James. Stay true to your treatment.
Thank you very much.
Thank you so much for sharing with us your journey this far. We look forward to having you again.
Hello.
Now, thank you so much for you who has been watching us from home or from wherever you have been watching us. We do appreciate you for making time. Be sure to join us again tomorrow morning right here on Good Morning Kenya for another fantastic edition. My name is Jen Wamboi. On behalf of the crew here, we wish you a lovely day. God bless. See you tomorrow.